Hello, I'm Dr. Laurence Klotz. I'm professor of surgery at the University of Toronto and a urologist at Sunnybrook Health Sciences Center. And I've been asked to talk about my views about the management of low-risk prostate cancer and particularly active surveillance and who should be treated. So this is an idea that began close to 20 years ago. And at the time, there was a resurgence of diagnosis of prostate cancer based on the widespread use of PSA as a screening test. And suddenly, we were seeing a great many patients with small volume, low-grade prostate cancer diagnosed on a biopsy on the basis of an elevated PSA. It had been known for many years that microfocal prostate cancer develops with age. And some key autopsy studies had shown that the likelihood of a man having some prostate cancer was about equal to his age as a percentage. So that means, surprisingly, 30% of men in their 30s have microfocal prostate cancer. It's about 50% of men in their 50s. And in elderly men, it is more or less ubiquitous. And it was apparent that we were finding these clinically insignificant cancers in many men. And the practice was to treat them because of uncertainty about what the natural history was. So we began an approach back in the around the late 90s, where instead of treating the patients up front, we managed them with surveillance. We repeated the biopsy periodically. We tracked the PSA, and we treated the patients who over time were reclassified as being at higher risk. And this is quite controversial. The idea of not treating cancer was very much against conventional wisdom. And particularly early on, to say to a patient, yes, you have cancer, Mr. Jones, but no, you don't need to be treated. This did not sit well with many patients, and it required a lot of education to get them to understand. So over the years, this concept has become more widely accepted. First of all, we have now quite robust data. Worldwide, there's about 5,000 patients being reported on prospectively managed in this way. Our own series of 1,000 patients was just updated in Journal of Clinical Oncology about 2 months ago. And in that group of patients, the prostate cancer mortality now at 15 years is 5%. Now 5% is not zero, but it's pretty low given that that is happening out at 15 years. Of those 5%, about half progressed to metastatic disease very early after diagnosis. And in retrospect, they look like they had higher grade cancer that was undiagnosed, unrecognized, that had already metastasized and they were incurable. Again, this is about 2% of the whole population. So that leaves another 2 to 3% of patients who may very well have had localized disease, who were followed for a period of time, and who eventually progressed and turned out not to be cured by the delayed therapy. So it's for those 2 to 3% that we are directing tremendous efforts now to improve the practice of active surveillance, and particularly to identify earlier on those patients who are really at higher risk. A second key development has been a much better understanding of what the genetics and natural history of Gleason pattern 3 or Gleason 6 prostate cancer is. And we now have very robust data from large data sets with long follow-up that patients who have only Gleason pattern 3, so that means they have been proven by surgical resection and examination of the entire prostate not to have higher grade cancer that is occult in the prostate. Those patients never metastasize. There don't seem to be really any very well documented cases in the world of a patient who had surgery for only Gleason 6 and went on to develop metastatic disease. And that's very reassuring. And so what it means is that the significance of Gleason 6 cancer, it doesn't pose a threat to the patient on its own. It does not metastasize, but it is a biomarker for the patient harboring higher risk cancer. And so that means you have to follow the patient, you have to repeat the biopsy. If something doesn't seem right, we move on to an MRI. So that could be rapid rise in PSA, it could be a significant change in prostate cancer volume of Gleason pattern 3, or it could be development of a nodule, or finding of a little bit of Gleason pattern 4. So the MRI is really a game changer in this area. It's allowing us to find the patients with more aggressive cancer earlier on. And we think going forward, that will be the solution to that 2 or 3% of patients who were badly served by surveillance. Having said all that, keep in mind you have about 3/4 of patients who are never going to require treatment. The ones who truly only have Gleason 6, who have clinically insignificant cancer, and these patients are able to completely avoid the significant side effects of therapy. The concept has been really reinforced by a widespread view by methodologists and other people involved in public policy that over-treatment and over-diagnosis of prostate cancer has been a major problem that has undermined the value of screening. So in my view, screening makes a lot of sense. I'm very pro-PSA screening, but it has to be joined with an approach that says we are not going to treat the low grade or low risk patients. We're going to restrict treatment to the patients who really need it. And I think that approach of combining an intelligent attitude towards patient selection for screening and for treatment makes early detection of prostate cancer much more appealing. And we hope in the long run, these groups like the U.S. Preventive Service Task Force will recognize this and take a more pro-screening attitude. Thank you very much.